Perfect. Sorry for the inconvenience. Okay, thank you for inviting me to this very interesting meeting. I'm going to talk for a topic about a topic that is very dear of mine. I have been always passionate of transcatheter mitral valve in valve. So disclosure, I am right now a full-time Edwards Life Sciences employee, which, by the way, I don't consider a conflict, because it's thanks of working in Edwards Life Sciences that I had the opportunity to proctor hundreds, I would say probably 300 mitral valve procedure, and I'm happy to share with you today all the learnings that I had through this past 8 years. So first one slide about outcome. So this is state of the art. Basically, in the US, more than 5,000 mitral valve procedures have been performed, and data are collected in the TVT registry. This slide shows that before the FDA approval in 2017 and after, until 2020, this data show that over time, transfemoral approach has become the predominant access route. Now more than 95% procedures are performed transeptal. Outcomes have improved dramatically since the procedure became on-label following the FDA approval. Mortality was cut in half, dropped to 3-4% 30-day mortality. So what is the secret sauce for such good outcomes? First of all, the use of transfemoral more than transapical, and the possibility to support procedure through training and proctoring. And so we got better in doing the procedure, but also we got better in screening and planning the procedure. And in my opinion, the use of valve-in-valve app and CT imaging have been the most impactful tools. It's very important to know the valve you are dealing with, and definitely the valve-in-valve app, it's definitely a great help here. These images are available in the valve-in-valve app, which is a very helpful tool. Obtaining correct information on the brand, the model, and the size of the surgical prosthesis is crucial for appropriate SAPIEN 3 sizing, positioning strategy, and also to assess the risk of LVD obstruction. Positioning, for instance, we need to know the fluoroscopic appearance of each valve, so we know exactly where do we want to position the SAPIEN 3 valve. As far as sizing, if you know the model and the size of the prosthesis, then you can also derive what is the actual internal diameter, called the true ID. And this information, once again, is available in the valve-in-valve app. I'm talking about the valve-in-valve app for sizing because CT sizing is very helpful, but cannot be used as the only tool for sizing, because sometimes CT sizing is not that reliable. So, and here's why. You may have a motion artifact, an example on the left, or misregistration artifact, or you may have blooming artifact, and the measurements error, it could be up to 2 millimeters, which is the difference between one size and the next one. Also, there are some prostheses like the St. Jude Epic or the Medtronic Mosaic where it's very difficult to understand how to measure the internal diameter. And the third aspect is how the different valves have a different impact in terms of LVT obstruction. Porcine valves have very short cusps. And so even when you stand to open the cusps, you don't have a complete occlusion of the space between the surgical posts, while pericardial valves have very long cusps, and so they have a higher risk of LVT obstruction. Of course, the way we assessed what is the risk of LVT obstruction is not just knowing what valve it is. We need to look at the images. And while CT is the main tool, we can also use sometimes echo by measuring the distance between the post and the septum. And if you have a 3 chambers view, whether a transthoracic or transesophageal echo, you can measure the distance. So you can see clearly if there's space for the outflow and if there's risk or not. But definitely, CT assessment is the most important. And the one parameter that is absolutely important is the knee LVT area, which needs to be greater than 200 square millimeters. And we have to use a CT, a good quality CT, to do that. Another thing that we can derive from CT imaging is the information about the transeptal access, not only if transeptal is feasible, but also planning of the proper location of the transeptal puncture. I mean, the previous speaker talked about the importance of avoiding a very superior puncture, and it's very helpful that you can plan this by CT. And by CT, in this specific case, we knew that we wanted to have an inferior and posterior puncture, and you can see the picture on the right, which is the same patient. You can see the indentation in the septostomy balloon, which is at the tip of the yellow arrow at the inferior edge of the mitral prosthesis. A fluoro view in straight AP can tell you if your septal puncture is too high or too low. Even just, not even looking at the echo, but just fluoro is telling you a lot. And this is the pictures from the same patient. You can see how with the proper septal puncture, then you have a very nice trajectory of the wire, a very coaxial positioning of the sapien 3, and you're going to have a very good outcome of the implant. You want to have a smooth trajectory of the wire, and you want to have a pre-shaped looping wire into the LV apex. We like to use pre-shaped wire because they are safer and you have less risk of LV perforation. It's very important to make sure that the pre-shaped loop is facing down, because that's what is going to give you a smoother trajectory and easier tracking of the delivery system across the septum and the mitral valve prosthesis. Then, of course, during the procedure, we guide the septal puncture using echo, and the first views that we use are bicaval, and we usually go inferior, and then we look at short axis, and we want to be usually posterior, away from the aortic valve. And so inferior and posterior puncture, in the vast majority of the cases, is the appropriate location. Then we double check using a third echo view, which is called 4 chambers in 0 degrees, and we measure the puncture height. And the imaging number is between 2.5 and 4 centimeters above the ring of the mitral valve prosthesis. This is the distance where it's easier to perform the procedure, between 2.5 and 4 centimeters. Then once you have done the septal puncture and you deploy the stiff wire, pre-shaped stiff wire in the LV apex, then at this point you can do the balloon septostomy. And we have to use a non-compliant balloon. Its size is usually between 12 and 14 millimeters. And I would like to share with you what I learned regarding the septostomy. 4 tips, I would say. I like a long inflation for 30 seconds. I like to double check with an deflator that the pressure is at least 4 atmospheres. You want to get rid of any waste looking at fluoro. Sometimes I like doing 2 inflations and doing a balloon run through the septum to make sure that you have a good trackability of the device. A correct septal puncture and a correct balloon septostomy and the correct use of the wire, these are the tricks that can ensure a smooth procedure. Here is an example where the puncture was too high, and then if you have a too superior puncture, you can see how the trajectory of the wire is not favorable. In this patient on the left, you can see how also the loop of the pre-shaped wire is facing up, which is not good. In this case, a second puncture was done and everything was much easier, as you can see picture on the right. So sometimes it's still challenging to track the delivery system across the septum, and what can we do in these cases? Something that I learned is to watch what happens at the transesophageal echo. You want to watch the progression of the valve across the septum, understanding if it's the valve that cannot cross the septum because the stent of the valve is catching onto the septal tissue, or because like the video on the top right corner, you can see how the stent of the valve is already on the left side of the atrium. However, the pusher, the flex catheter, is catching onto the septum. In this case, you just have to telescope and advance the stent of the valve across the mitral prosthesis, leaving the flex catheter all the way on the right side of the septum. So this is a summary slide where basically these are the three possible bailout solutions in case you have challenging tracking. Sometimes you need to do a new puncture. In some situation, you can snare and elect to snare the loop into the LV apex. You can snare this wire coming through the aorta or coming through the transeptal axis again. And by using a JR4 cutter, you can stabilize the snare and push the looping wire into the apex to have a nice and stable wire, so you can have more trackability. Or in some situation, you can actually perform a second, more generous septostomy with a bigger balloon. And you can use the left femoral venous access for that. So now talking about positioning, the picture on the left is showing the most challenging valve, maybe because the mosaic has only eyelets at the ventricular end of the surgical post, and you don't see the ring. While the picture on the left is showing an Edwards perimount valve, which the stent is completely visible. It is much easier to have a good positioning. Remember, the foreshortening happens from the atrium. You don't need to pace 200. Sometimes we pace 140. You can have a long pacing, no problem. The pressure is not going to drop below 80, and you can have a long pacing. Now I want to share an example of a bad deployment in a mosaic valve. Like I said, mosaic is a challenging valve because you only see the ventricular end of the posts and you don't see the basal ring of the prosthesis. In this case, you can see also that the valve is not coaxial, it's very canted. And because you don't see where is the ring, the risk is that you push the valve too far into the ventricle. Like as you see, this operator pushed the valve too much deep into the ventricle. They started inflation. They were not realizing that the valve was getting too deep into the ventricle. And in this situation, when they realized the valve is too deep, it was already too late. You can see at this point that the inferior portion of the stent is already too low. It's already past the basal ring, and then there's no recovery at this point. They try to pull back the commander delivery system. The commander is not coming back. At this point, you can only deploy the valve, and hopefully the valve is not going to embolize. You can deploy a second valve and save the day. I have seen this complication only on mosaic valve and when the valve is canted. So my recommendation is that for mosaic valve, don't go too deep and take your time and make sure you have a more coaxial positioning. And I thank you very much for your attention.